Welcome. My name is Dr. Stu Fischbein. I'm a practicing obstetrician in Southern California. I've been in practice since 1986 when I finished my residency at Cedars-Sinai Medical Center, and I'm a fellow of the American College of OBGYN. I'm here to talk to you on the behalf of BIRTHFIT on birth options in America. And I feel I'm uniquely positioned to comment on the two main options in the United States, which is the hospital-based birthing and home-based birthing, as I spent the first 24 years of my private career in hospital-based birthing. And then over the last 10 years plus, I've been solely collaborating with midwives and working in the home setting. So it does give me the unique position to comment on the differences between the two. As you know, most people in the United States are born in the hospital, probably 98 to 99%, depending on what state you're in. And the practice of midwifery is far less consistent and accepted in some states versus other states. But let's talk a little bit about hospital-based birthing, because that is where most women are going to give birth in the United States. My feeling about the hospital-based system is that it's in need of complete refurbishing, or to quote a recent political term, it needs to be reimagined, because what's going on right now with hospital-based birthing is not good. We have gone from a system that in 1970 had a cesarean section rate of 5% to a system now that has a cesarean section rate above 30%. And we have not seen a concurrent decrease in the rate of cerebral palsy or hypoxic ischemic encephalopathy, which sort of was the purpose of bringing birth into the hospital, was to improve outcomes. So we've had a 500% increase in the cesarean rate in the United States with not much to show for it. And I put the responsibility for that mostly on what I would call stage one thinking, which is the idea that we were going to bring in the Friedman curve and we were going to bring in continuous fetal monitoring, and that was going to solve all problems regarding labor. And of course, by catching things early with the fetal monitor, by moving things along with the Friedman curve, we were going to optimize labor and get better outcomes. But that has not been the case. We have not seen any statistical significant change in the rate of cerebral palsy, but we have seen a 500% increase in the cesarean section rate. This is a problem with the system that we have right now, which is medical based, where it looks at obstetrics as a medical problem or pregnancy as a medical problem. And about 85% of women, it's not. It's actually a normal function of the human body that like breathing or digestion will happen whether you want it to or not. And if you leave it alone, then you're far more likely to have better outcomes. But the hospital system just doesn't do that. And there are many reasons for that, including economic, expediency, medical, legal reasons. For the most part, we're not going to get into those in this particular introduction here. But just to say that the hospital model does not respect the process of birthing. In other words, it places all women into an algorithm. They all should dilate at the same rate. They all should not be eating. They all should not be allowed to move around. They need to be monitored. They need to progress at a certain rate. These things are not how normal mammals give labor. If I could digress for a second and just talk a little bit about mammalian birth. If you think about how a dog or a cat or a horse or a deer might give birth, the first thing they do is they go off to a quiet place and they go off by themselves. And if they're hungry, they eat, and if they're thirsty, they drink, and if they're uncomfortable, they move, or they roll, or they get up, or they pace, or they lie down. And no one's really bothering them. When they're bothered, by the way, they'll put out adrenaline. When a predator approaches or little kids run into the bedroom, they'll put out adrenaline and they will stop labor and they'll get up and run away. And only when it's safe will labor ensue. And in this way, nature ensures the best chance for success and survival. But and then when the baby is born in the wild, it falls into the dirt. It's not a sterile procedure. Nobody rushes in to cut the cord, and nobody ever separates the baby from the mother. And that's typically how mammals give birth. And when you interrupt with that, then you cause a cascade of hormonal changes and interventions that interrupt the process. For instance, when a woman leaves her house when she's in labor and goes to the hospital, she's asked to pee in a cup and change clothes, and sign some documents even while she's contracting every 3 minutes that talk about surgery and death and other things that you don't even know because you're not going to read it, you're just going to sign it. And then you have an IV put in you and you put belts on you and sort of you're immobilized and you're not allowed to eat much but ice chips or a popsicle. And you're constantly being interrupted and you're asked questions about things that really don't matter, like how many stairs you have in your house or what did your grandmother die from. And this is not something that really needs to be answered at that particular time when a woman is contracting and being bothered by that. And then you have people sitting around staring at you, whether it's the nurses or your family members. If you were to do this to your pet when it was in labor, well, first of all, you would never do this to your pet in labor. And if the children are bothering the dog or the cat, you tell them to leave the cat alone. And yet, in the hospital model, everything that's done is antithetical to nature's design. So it's not surprising that we go from a C-section rate of 5% 50 years ago to a 32% C-section rate now. And this can't be considered good. So the whole hospital system needs to be reevaluated because the economic incentives are all backwards. I mean, quite frankly, hospitals get paid more for a cesarean section than they do for a vaginal birth. Doctors don't really, but hospitals do. Doctors save time when they can do a C-section at 7:30 in the morning on a Tuesday. Then they have to be there because of some hospital policy, because they have a VBAC or a breach in labor, and the hospital makes them be there. Nobody wants to spend all that time in the hospital for the same payment that they would get if they did a C-section and were in and out in 45 minutes. So all the economic incentives, the medical legal incentives, the expedient incentives, they're all backwards, and they're all forcing the system to continue as it is. But there is a better way, and I saw that when I was a resident, when I was a resident, but when I finished my residency and I began practicing, I began backing midwives. Not because I thought it was a good idea, because I was trained like every other OB is trained to think that that OB is a medical problem and people having home births are crazy. But because I was a mercenary and I was trying to make money. It was a different era back then. I was trying to build a practice from scratch. It wasn't like I came out and got a salary like a lot of doctors do now. I didn't work a shift. I hustled and worked in a lot of emergency rooms, but I began to back midwives up, take their transports, and I began to see a different way of doing things. And it made a lot of sense to me. So I began incorporating that into my practice over the years, and finally reached a point where, because I was lucky enough to be trained in breech delivery and second twin breech delivery and forceps and vacuums because of where I trained at Cedars, which had a relationship with LA County USC Hospital back in the early 80s, which at that point was the busiest hospital in the country, doing about 20,000 or 22,000 births a year, which is about 65 babies a day. So if breaches are 2 to 3% of the population, or 3%, you're going to see 2 to 3 breaches every single day that you're on call. So you get these skills, and I wasn't being allowed any longer to do them in the hospital. The hospital policymakers, and we'll leave it at that, had decided that maybe we won't let midwives work here, maybe we won't do VBACs, maybe we won't do breaches. Maybe we should section all twins or induce them all at 37 or 38 weeks without thinking on the long-term consequence, or actually not thinking, what does the woman want? What does the family want? And what is our ethical obligation as physicians to give true informed consent and then accept the process of patient making decisions, which includes the right to refuse the recommendations that you might be making and still support them. These things are not sort of smiled upon in the hospital setting. They want to expedite things through. So I ended up leaving in 2010 and going into the home-based world, where about 1 to 2% of women nationwide are delivering their babies at home, maybe slightly increased since the coronavirus outbreak, but not substantially increased. And I find that the success rates are higher, the intervention rates are lower, the patient satisfaction rates are significantly higher. And there's a lot of data to support this, and maybe at some future time I can give references, or if BIRTHFIT lets me, I can put references at the end of this video for you to look into some of those things. But mammals do it differently, and we need to respect that. And when we interfere with that sort of system, we end up with all these interventions and not better results. And as a matter of fact, I mean, we're not even talking about the long downstream consequences of a higher C-section rate and the risks to the future babies, the mother's health, and the baby that was born by cesarean section, especially the scheduled pre-labor cesarean sections, which tend to have slightly higher rates of childhood asthma and autoimmune disorders and adult onset diabetes. And we're learning more and more about the microbiome, and we're not being respectful of it in the hospital setting. Also, the way we counsel patients in the two options for birth in America is significantly different, as I've seen. There's a tenet in medical ethics that, given the same information, two people should not be expected to come to the same conclusion. And yet, people are given counseling to funnel them down a path or skew them down a path to get them to do what the physician or the hospital wants them to do. And a lot of times they'll use relative risk over actual risk. So the way I describe that is that if something were to happen in California once last year, the rate would be 1 in 40 million. And if it happened 10 times this year, there would be a relative risk of 10-fold increase, but the rate is still 1 in 4 million, which is still essentially zero. So relative risk doesn't mean anything when you don't know what the denominator is. And so many doctors will say, well, it's risky because you're 35, or it's risky because I think you have a big baby, or it's risky because you're getting close to 42 weeks. But they'll never give them the actual risk. And in order to make an informed decision, our clients or patients need to know what the actual risks are. Otherwise, we're just skewing our counseling. And that's not ethically correct. And that is ingrained in the hospital-based system. And I see much more respect honored in the home system, which is mainly staffed by midwives, midwives have a different model of care. So let's talk about that for just a second. What's really different? Well, first of all, they don't see pregnancy as an illness. They see pregnancy as wellness, which occasionally goes wrong. But generally, when you don't meddle with Mother Nature, you don't see the sudden or rapid deterioration in fetal status that you see in the hospital, where they end up, starving a woman, immobilizing a woman, epidural, Pitocin, fetal intolerance to labor, and an urgent or emergent C-section. You don't see that at home. And that's something that a lot of people who've never been to a home birth don't understand. Midwives also, I think they honor the informed consent model much better. Their prenatal visits are generally 30 to 60 minutes long. Pretty much 60 minutes long. Mine are a little shorter because, frankly, I run out of things to talk about in 60 minutes, but I give every OB visit 60 minutes. You can't do that in the obstetric model of care because the reimbursement isn't enough. You can't see one patient an hour and make a living as an obstetrician, but you can as a midwife, because you can work outside of the insurance system, outside of the pressures that doctors feel when they work in a hospital system. So midwives, and then midwives see mother and baby as a unit. In the medical model, we take care of the mother who's pregnant, but once the baby's out, the baby belongs to the pediatrician. So a lot of times, our goal as obstetricians is to get the baby out so that we can say, whew, and we're done, and then we'll just deal with everything that comes afterwards. And so cesarean section is a tool that's used, and not just saying because of that, but certainly there's a relief factor in the physician when the baby is out and crying, because now the baby is no longer that physician's responsibility. The midwifery model looks at mother and baby as a unit. So they are always thinking, what's better for mother, what's equally good for baby. And then once the baby's out, the midwives are experts in postpartum care. They do it much better than we do. In the medical model, a lot of times the woman goes home on the first or second postpartum day, and the doctor says, I'll see you in 6 weeks. And there is no follow-up care in between, other than if the patient wants to hire a lactation consultant or postpartum doula or something like that. But that's not usually the purveyance of the obstetrician. Whereas in the midwifery model, there's a saying that it's midwives for lives, or for life, a midwife for life. And the midwives are available 24/7 afterwards. And they're experts in nutrition, they're experts in lactation, they're experts in emotional support. And quite frankly, they're far better at it than I ever was. And although I've picked up a lot, I freely admit that I'm not a midwife and I don't do what they do. That brings me to one other point that I should make about midwifery. A lot of obstetricians think that midwives are just a lesser subset of their profession, and they're not. It's a completely separate profession, and they should govern themselves, and we shouldn't be putting restrictions on them that we see from our model, because that we're projecting onto them how we would deal with things, and that really isn't right, and I'd like to see a change in that as well. Also, because hospitals have banned sort of breaches and twin deliveries, and they're doing sections on twins, and they're inducing them for 38 weeks, and they're not giving them the true informed consent of the risks of that. I've been doing them at home, and what is traditionally labeled high-risk pregnancies, I found that really when you give people informed consent, they're not as high risk as you think. And again, things don't change that dramatically that you can't do these things at home. In an ideal setting, you could treat women equally in the hospital setting, although it would never quite be the same as not leaving your house and not leaving your nest. But all things aren't equal, and they're not going to let you do these things in the hospital. So even if you want to have a breech delivery, there's no one in the hospital who's going to support you. And if you want to have a twin delivery and you don't want to be monitored completely, or your second baby is transverse via breech and the doctor isn't comfortable doing a breech extraction, no one's going to help you, and they're going to skew their counseling to get you to have a cesarean section. So that's basically the big difference. So I as a home birth obstetrician, working in collaboration with midwives, I think it gives the best of both worlds to the women of our country. And I'd like to see a change in the system. When you mess with Mother Nature, okay, you're going to have ripple effects downstream. And the midwifery model is much closer to Mother Nature, and I think it can do a better job. And if nothing else comes of this project, and what I'm saying is ideally I'd like to see, as my friend Augustine Colbrooks likes to say, I'd like to break the silos, and I'd like to see midwives spend time in labor and delivery. Residents and nurses from labor and delivery spend time in the home. You know, people that are critical of home birth have never seen one. And many midwives have never been to a hospital birth and don't understand the situation or the pressures that they're under either. And there'd be much better collaboration and camaraderie if we could all sort of work toward a common goal, and that's the betterment of women's health care. And normalize birth, because it is a normal function of a woman's body. And again, if you leave it alone, it works really, really well most of the time. So thanks for listening. I'll see you soon.